Okay. So please get your registration done by next week or earlier, so that next Thursday when we're online together, I will have gone in and I'll be able to see everybody's names. If you're having any trouble, please reach out to me and I will be happy to help you. The other thing that this helps us with is the funds that are going to support both the training and also the bonuses that come as a result of completing it. They're connected to something called RI Reconnect. Have you guys heard of this? Anybody? I hadn't heard of it. So when I wrote this grant, one of the things that was made available in my grant is that we have some funds if people need to pay someone for childcare so that they can participate in the trainings, or maybe you're taking care of an aging parent and you need someone to stay with them so you can do it. There's money for that. There's money to help if you're having trouble being able to connect to the internet, some money to help pay for that. And I think that there also may be some money about transportation, like say that you had to go to your agency and use their computer or something like that to do it. So I have some of those funds and I'll reach out to folks and you can certainly chat with me privately. You could send me a message in the chat tonight and let me know if there's anything that we can do to support your participation. But these resources and the ones I'm about to share with you were made available because the long-term care workforce, as well as other members of the healthcare workforce, have been disproportionately affected by COVID. We find that folks working in this field have had their employment challenged because of COVID. You may have had to go on unemployment. With the numbers going back up, there's a risk to what is or isn't going to happen in facilities and how that might affect you. And in an effort to make sure that Rhode Island is supporting critical first responders, they've added supplemental resources. And so this is what I found out last Friday. And so I was really excited to be able to share them with you. I'm going to give you a quick overview, but next week we're going to be visited by one of the leaders of this program. His name is Omar, and he'll spend a few minutes with us, I think at the beginning of class, just sharing about the program, giving you his contact information. And once you're enrolled in with the form that I sent you, the DLT system, that makes you eligible for these different supports. So some of you might say, oh, I don't need any of that. And then some of us might say, wow, that would make a big difference. So I just want to give you just a basic overview of what RI Reconnect is, and then Omar can fill in the gaps. But they're working to provide support that help prevent and remove barriers to employment in advanced education. And so Omar has staff called navigators, and they can connect with the folks going through our trainings and help them with resources, coaching around job placement. And what they do is they assess, what your needs might be if you have any. They look at barriers that are directly impacting your ability to participate and that might be threatening future employment opportunities. They can provide education, coaching, soft skills like practicing interviews, career advice. And then the other thing that they can do is they can look even more intensely at some of the things that make it hard to go to training. I had the last training that we did at Crossroads, we had 4 people participating, and they were all struggling. Sometimes the internet wasn't working. Sometimes the phone wasn't working. They didn't have a computer. Like, those are folks that I could have really helped out. I could have helped them get a computer or an iPad. I could have helped them with their internet connection and that sort of stuff. But now these resources can. And so I wanted to just show you really quickly what the resources include. So it can be all of these things here. So utility bills, rent, emergency housing. There have been a number of people who have lost their housing because of layoffs with work, which then prevented them from being able to pay rent, childcare, bus tickets, Uber ride, clothing, getting your hair cut, technology. So if you don't have access to a phone or a laptop or a tablet, helping with that, connecting you and helping you stay connected to the internet, and all of these other things down at the bottom.
That's why. You know, that's funny. I wanted watermelon anyway.
So I want to make you aware of that. One, so that you'll know that these resources are there. And two, so that you can think about if there's anything that you might need that could help your participation in this training be a little bit smoother for you as you kind of navigate some of the things. Like we heard from Carla that there was COVID in her facility and she hasn't seen her colleagues because she's been quarantining, right? So all of these different challenges, in more than a lot of other professions, first responders are being affected more. And when you think about who we need to be present to care for people who are more vulnerable, it's all of you guys. And so apparently the governor put some resources behind making sure that we are taking care of our first responder healthcare workforce members. And so you can think about how that might be helpful. You can send me a chat privately and let me know if there's anything in particular you're interested in. And then when next week, when Omar comes, he'll have more direct details, and I'll be able to, for those of you who might be interested, I'll be able to connect you with him by virtue of your enrollment in the DLT system. Okay, so that's why it's so important to get in there by next week. And you can enroll and decide that you don't want any resources or supports. That's fine too. But the enrollment will have DLT pay for the cost of the training, as well as if you wanted supplemental services. Does anybody have any questions? Nope. All right. Excellent. Hello, Renee.
Hello, Renee. That sounds pretty good, Tanya. It's nice to have the support.
Yeah, I mean, it's actually it's the first time that anything of this magnitude has been offered. So when I found out on Friday, I couldn't believe it. I was really excited. So, all right, I am going to turn it over to the good doctor.
Hey, thanks a lot. I appreciate it. Welcome back. Welcome back. I wanted to say that I thought the conversation that we had last week was really productive. And I was wondering if somebody would give a little bit of a review on what we covered last week and maybe how it was relevant to something that happened that you, in terms of your work during this past week. So what did we talk about real quickly last week? And, you know, what's the relevance so far in terms of what you've been doing? Stress relief.
Well,
yeah.
I was just going to say that I remember the two things at the end of our conversation that you thought were important were bringing the light to a situation and the bottoms of our feet, and thinking about the bottoms of our feet.
That's right.
And I told my therapist that she was a big topic of discussion last class. So she's like, good. So it's good. Those are the two things that I remember. And basically, you know, coping with stress and ways of dealing with stress and how we handle it appropriately.
Yeah, you know, right. And, you know, we talked about some strategy around appropriate handling, but I'm so glad you said that, because to be honest with you, I forgot that we had that. And that was great. You know, bringing the light, you know, that's a nice metaphor for trying to help a patient facilitate through all this uncertainty. And certainly, you know, staying grounded and connected is a good strategy, I think, to, you know, to deal with all this insipid stress that we're all experiencing. You know, we really have to sort of ground ourselves and center ourselves. So, you know, it's good. You know, the light thing is good kind of metaphorically. It's a good general idea of what's going on. And also the grounding is a great specific strategy. So that's good. Yeah. You know, the stress is all around us. It's ubiquitous. You know, we certainly have to model how we deal effectively with stress for the people that we work with, our patients, because they pick up on us if we're kind of stressed out. and obviously they're going to pick up on that. So so that's great. Yeah, I mean, those are little pearls of wisdom that that sort of came from our discussion, sort of generically. It's amazing when a bunch of people put their heads together. Some of the stuff, it's the good stuff that can result from that. So thanks for sharing that. Yeah, I'm glad I had a chance to think about that again. Now I think it'll stick in my mind. So what else did we cover? Anything else from that around applicability to something that you've done, where something we talked about last week, you've actually applied, and what it was successful or not? Nicole, you said something about strategies. Nicole? Walking away. Okay. Cookie, you look like you want to say something. It's like right on the tip of your...
Being aware to walk away, when to say you're at your limit. You don't want to overdo it where it's physical, stressful too.
Yeah, I guess what you're
Know
saying.
your limit.
Yeah, to kind of know when you're when you need to recharge the battery, or you need to right. I think it's an issue of self-awareness, right?
Exactly.
And you have to be self-aware. You have to pay attention to it so that you can deal with it. If you're not self-aware, then things are going to happen and you're not going to be aware of it. Dealing with different stress, reflective practice. That's another really, really important point. What does reflective practice mean to you? I think that's a very important point. When you're reflective about your work, what does that mean?
I actually typed it in because of what Cookie said. And I also think Jenna's comment in terms of being ready to pivot. And then also Cookie said, know your limits. So when you're reflective and you know what pushes your buttons, you can make sure that you take yourself out. And that self-awareness can make you a great tool for others, but especially yourself. Right.
So it's good for you, but it's also a good way to model kind of what the value of being self-reflective or self-awareness is. Yeah, I think they go hand in hand, right? You have to be first aware, and then that awareness allows you to reflect on what's going on, and then you could choose a corrective course of action, like Tanya said, around pivoting. So yeah, I think it's very important for us to pay attention to ourselves, especially in the kind of work you do that is so demanding, and so it can be so stressful. I think you really have to pay attention, be aware of your own pulse, so to speak, and pay attention to where you are. I think it's really, really important. All right. Anything else from last week around what we talked about? Bringing in the light, being grounded, dealing with stress, being self-reflective, making sure that you're self-aware what's going on with you. You're change agents, right? You're change agents. And we're going to spend time talking about how that happens and what are some strategies. And if you're going to be effective, then you have to pay attention to yourself. So those are great points. There was something around stereotyping as well. Nicole said, what is it about stereotyping people? Nicole, did you say that?
Yep.
All right. What you want to talk a little bit about that?
Making judgments on people you don't know.
Yep. That's what it is. What's the harm in that?
Great question.
I mean, what happens when you make judgments about people? Well, maybe one of the things happens is you shut down the conversation, right? It affects connection. Yep, that's exactly right. When you don't allow for a conversation, you're shutting things down, or like she said, you're shutting down connection. So that's exactly right. It's very easy for us, I think, to be judgmental. And I think it's very easy for us to stereotype, particularly in our weaker moments. But I think we have to try to suspend judgment, and we have to appreciate the fact that many times our initial impressions are not exactly correct. So, I think that's a very important point as well. Right? So if you stereotype people, you make judgments prematurely, what happens? People don't open up. They don't open up to you. You don't allow for a space for things to morph and things to develop the way that they should be. So those are good points too. Why do you think we stereotype? Why do you think we make these judgments prematurely? What is it about us sometimes that we're judgmental, maybe prematurely? What is it about us, do you think? Maybe we're a little bit insecure. Maybe we're a little bit uncomfortable. What other kinds of things might get? Do you do that sometimes with patients, only to find out later that maybe your initial assumption was incorrect? I know I do that sometimes.
Us as people, we like to have everything be in black and white, written out. We don't really like to look outside of our comfort zone. So I think that's why we stereotype a lot of the time, because it's something we're not used to, and it's like, quote unquote, out of the norm for some of us. So I think that comes with stereotyping.
Right. I think that's right. And I think because of exactly what you said, that sometimes we like to put people in boxes because it's more comfortable for us. Or like you said, we tend not to see things in the full range that they are. We try to, we end up thinking about people in very black and white terms. I think to some extent it's a little bit protective, and it's a little bit of a safety issue. We think if we can make a judgment quickly, we can assess whether or not, at a very fundamental level, we're safe. But I think you're right. I think it does us a disservice because, if you're going to be effective in your work, you have to stay open. And many times, I've learned for myself, sometimes my initial judgments, particularly in casual situations, are incorrect. So I try to give myself the benefit of allowing some time before I make a judgment. And it's sometimes not easy though, because I think we do it reflexively. We do it automatically sometimes. So those are good points. All right. Anything else from last week that you wanted to talk a little bit more about, or there was some ambiguity or some questions about it? Anybody?
No, but
Okay.
I just wanted to kind of say something
Sure.
regarding stereotypes. So I'm the director of social services at a facility, and we do have a very tough clientele. And I'm trying to change how, when we call 911 or when we send a resident out somewhere, I'm trying to have them understand different aspects about my residents, that they're not, just people who were homeless, people who were, drug addicts or have mental disorders. They always give them such a hard time when we call, and all I ever want to do is give people a paradigm shift on that type of the clientele that we host. And it breaks my heart that society and community just does not see that. When they hear my facility, oh, you guys again. And it to be a professional and to stick up for your residents is such a hard, I don't know what the right word I'm trying to say, so I'm sorry, but it's so hard. And all I want to do is change the stereotypes for people with mental health. It's all I ever wanted to do. That's why I feel like I'm in this, for that particular reason in general.
Carla,
What facility are you at, Renee? I mean, Carla and Renee, you guys work together.
Me and Nicole work together.
Okay.
I'm at Autumn Villa Assisted Living.
Oh, okay. Huh. Okay.
So we house the schizophrenia, bipolar, drug and alcohol, some homeless. We have our veterans. We have maybe one or two of your typical quote unquote grandma, grandpa, but we don't really house that. And unfortunately, no matter who we call for 911 or, we need the police for assistance or something, it's never they're coming because they want to be there or they should be there for them. It's always and I'm so sick of fighting the fight, but I'm going to do it till
Right.
fight no more.
So the people that are making these judgments are who? The police, the EMTs, people who come?
Yes, I have met every chief in Cumberland in both fire, rescue, police. I mean, you can ask Nicole. I don't back down. I have called the Department of Health. I have exasperated my resources, but it's tough. And it's not all the time, but the majority of the time when we need to call, it's Autumn Villa. And it breaks my heart. It really does.
Yeah.
So not only our stereotypes of the people that we work with, but it's the community, how they view things too.
Yeah, we talked about, those are great points because, we had or should have a conversation, around stigma and making these judgments about people who have behavioral health issues. The fact that you advocate so strenuously is a wonderful thing. I think, though, the reality is there has to be education on the other end. Not that education is the solution, but sometimes it's a lack of understanding and education that really causes some of that the stigma to occur, and for that kind of behavior to happen. It's really so counterproductive because it's really not helping anybody. And it just sometimes exacerbates and makes worse the situation rather than doing something sort of to de-escalate the situation. So, I appreciate your advocacy. But I think education has to go the other way too, right? I mean, people who do that kind of work need to be more aware of what's going on, because again, it's the same stuff that we're talking about here. If they can't suspend their judgment and they see everything in a very black and white way, that's certainly not going to be helpful to your residents. So I appreciate that. And I know, sure, it gets frustrating because it happens over and over. It becomes repetitive, and you just feel like you don't make a lot of inroad. So I hear you. Yeah, how do you get to them? How do you provide the kind of help that they need to sort of see their job in a different way and see the residents in a way that's a little bit less, that's more advantageous to what's going on, so that they could be helpful as well. So those are systemic issues, right? Those are big picture issues to some extent. Yeah. All right. Well, Jenna just came in, so welcome, Jenna. All right. Thanks for sharing that. I appreciate that. Let me think about that a little bit and mull that over. Certainly your advocacy and your belief in what you're doing certainly comes through, right? So I pay attention to the emotionality, not just what you're saying, but how you're saying it.
No,
So.
I'm sorry. I'm so emotional about it.
No, I mean,
it's just a
no,
fight.
it's
I fight constantly on it every day, whether it's, when I admit somebody, for mental health with the hospitals, and it's just, I'm
right.
constantly battling it.
Yeah. And it gets, and I can certainly appreciate the frustration when you keep trying and nothing's, you 2 steps forward, 1 step back.
Mm-hmm.
Right. All right. Well, thanks for sharing that. I appreciate it. All right. So, I think what you looked at for this week had to do with the behavioral health disorders. And I think there were a number of behavioral health disorders that were discussed, including anxiety and I believe depression. And I think there was something in there around PTSD and so forth and so on. So I thought we'd spend some time talking about those, give you an idea, or listen to what you've learned about that. And then I could certainly add some additional material or answer questions. And again, talk a little bit about applicability to your settings. But, behavioral health disorders, in many ways are very much like medical illnesses. And I say that because they affect, a behavioral health disorder will affect every aspect of your being. Your physicality, your emotionality, your cognition, your behavior, your interpersonal relationships, and on and on. So behavioral health disorders are very much like other kinds of illnesses, in the fact that they're so pervasive and can be so difficult to deal with. And I think there was something in the slides around some Ds. I don't know if you recall those Ds. Do you recall those Ds that were in the slides, those 4 Ds? Anybody remember what those 4 Ds are? Anybody want to give it a shot? What were those 4 Ds that were talked about around behavioral health disorders? One was what? Distress?
Distress.
Good. What else?
Deviance.
Distress was one. I'm sorry. What was another?
Deviance.
Right. Deviance. Absolutely. Good. What was another? Right. Dysfunction.
And danger.
Right. Great. So we have these 4 Ds: deviance, distress, dysfunction, and danger. So how does that resonate with you? What do you think the value is in looking at those 4 Ds as they relate to behavioral health disorders? Helena? Yeah, it looked like you were gonna say. So when we look at these 4 Ds, what's the value of these 4 Ds? One of the values maybe is that they apply to all of the behavioral health disorders. So when we talk about anxiety, we can talk about how these 4 Ds apply to anxiety. When we think about depression, we think about post-traumatic stress disorder. right? When we look at some of these behavioral health disorders, addiction be another great example. When you think of these behavioral health disorders, these 4 Ds apply. And the value of them is that it gives you an indication of how serious that particular behavioral health disorder is for that individual. So if you look down the list of these Ds, you know, and you make an assessment around these Ds for your patient, it'll give you an indication of how serious or how severe the behavioral health disorder is. Does that resonate? Does that seem to make sense? So why don't you, we're going to start with anxiety, right? Yeah, well, an urgent ER visit, right? I mean, certainly going to an emergency room certainly activates those 4 Ds, right, in a very real way. Why don't we talk about how that happens? You know, you go to an emergency room or there is a behavioral health disorder that you want to be addressed in an emergent way. How are those 4 Ds affected? Is there danger? What would be the danger? And there could be a lot of different dangers, but give me an example. Say the person goes in, right, self-harm. Good. Right. So there's a danger of self-harm. That's great. Or you know, there could be suicidality, and as Nicole said, there could even be homicidality. Right. So one of the dangers is self-harm or harming somebody else. That's certainly a clear danger. What about the notion of distress? How would that apply? When somebody goes to an emergency room, obviously they're going to be in a lot of distress, right? And how does distress play out? How would distress play out? How would distress play out in a situation like that? Cookie?
Overwhelming. It could be very dangerous. Just
Right.
not good.
Yeah, distress could mean, and it could be that you're psychologically confused, or you're in great fear, or you're ruminating, or there could be obsessions. You know, you could be difficulty focusing. I mean, distress. Right. You could have physical symptoms, right? You know, your heart could be racing. You could be having, your blood pressure might be elevated. I mean, all kinds of things, right? So distress can play out not only psychologically but also physically. So that's another D. So what about dysfunction? How would dysfunction play out? So anyone? Paula? I'm going to call on Paula here. What about Jenna?
Maybe by the person having like abnormal behavior.
Yes, right. And that would even play into the other one around deviance, correct?
Yeah.
You know, deviance is another one of the Ds. So you're absolutely right. You know, the thing about deviance is it's a little bit subjective. You know, I don't think of deviance necessarily as always being negative. You know, you can be deviant in a positive way, but certainly when we think about behavioral health disorders, we see a certain level of deviance. You know, in other words, it's, you know, when I think of deviance, I think of it as outside the norm. So deviance is any kind of behavior or thought or feeling, right, that is a little bit outside of the norm. And when you think about behavioral health disorders, you're going to see some deviance. And again, we have to be careful how we judge that, but clearly you'll see that as well. So, you know, what we're saying here with these 4 Ds is that they apply to all of the behavioral health disorders, right? Avoiding eye contact, someone said. Yeah, you know, people avoid eye contact for a lot of reasons. You know, it's hard to interpret why that's happening, but clearly it can be a sign of deviance. You know, it could be cultural, right? Could be cultural. It could be a lot of things, but certainly eye contact is something that you would pay attention to as well. So, you know, when you think about these Ds, again, you know, what we're trying to say here is that you know, they're equally applicable to behavioral health disorders. So as we go through some of these, starting with anxiety, you can tell me how you think that these Ds play out in these behavioral health disorders, beginning with anxiety. And again, by assessing these areas, you get a good sense of how seriously impacted your patient or resident is. So Carla, you were advocating about people coming when there was an emergency, correct? When one of your residents has an emergency, I'm guessing that these 4 Ds are in play. Is that a fair statement? Right, Carla? When there's an emergency and you need to get somebody in there, whether it's EMT or the cops or whatever, your resident is experiencing issues across all 4 of those areas.
100%.
Right. And so by assessing those and having an understanding of how those are playing out, you get a better sense of how to intervene.
Exactly.
You get a better sense of what intervention is going to be most appropriate, right? So, these Ds are helpful not only from an assessment perspective and a severity perspective, but they're also helpful from a treatment or an intervention perspective. So there's value in understanding how people are impacted who have a behavioral health disorder in these 4 Ds. And I can tell you, you don't even have to have a behavioral health disorder. If something is going on in your life that's causing a lot of issue, you're going to be impacted in the very same way. So it's not like the residents or the clients or the patients are that different than us. They might be a little different in severity or acuity, but in a sense, these Ds are equally applicable to us when we get anxious or we get sad or we've experienced some kind of traumatic event we perceive as trauma, right? Or we've had a grief and loss situation, or we have an addiction issue, or we're stuck in a habituation. We're all habituated. These Ds are going to manifest themselves. And by paying attention to them and understanding what they are, it gives us a good sense of how to intervene, what to do, what should happen next. So I think they're very useful. They're very useful because they have broad applicability, regardless of the issue, behavioral health disorder that you're experiencing. I would even say with medical illnesses, you get diagnosed with a serious medical illness. These Ds can be in play as well. So again, they have very broad applicability. So it's not just something you learn about because it's fun to learn. It's something that can be helpful to you in assessing where your resident or your patient is when they experience symptoms of these behavioral health disorders. So it's very useful. All right, I'm going to just stop talking for a second and just ask you how that resonates, or how you have seen these Ds play out in the patients or residents that you work with.
So I've had residents who have wanted to kill themselves. They've given me letters stating that they were going to, that they had plans, that they just couldn't take it anymore, that they just feel like this is not what they want to be. They never thought they were going to be in a facility. I mean, that's another thing too, is they never thought they were going to be in a facility. So they can't always handle the fact that that's where they live. They get very antsy. So de-stressing them, talking to them, getting to know the person. I mean, I know them, them inside and out. So when a situation occurs, I feel like I can talk them down, and I don't get so scared and think that they're going to do something immediately. Like I feel like I'm in a different situation when something like this happens, because I know them a little bit better. Like Nikki knows them too. When something is for her. I mean, if someone's having a heart attack, that's a very different story, because he's out the door. But if someone's like going to harm themselves or fighting with others, or I mean, it's very easily that we can kind of work it out.
Yeah, when you talk about the
suicide, is that what you were kind of asking?
Yeah, when you think even about the suicidal client that you have good rapport with and you're able to sort of work with them, when you get in there and you begin to engage them and you have a conversation with them, in a sense, you are assessing around those 4 Ds, right? When you think about danger, it's the issue of safety. Are they safe? You assess how much distress they're in, because obviously the more distress they're in, the higher the level of acuity, right? When you think about deviance, you assess how much of their behavior and how their actions have changed based on their suicidality. You know, what's their functioning look like before they were suicidal, and what's it look like now? Again, which gives you some indication about the lethality. And then, you know, so again, when you look at these Ds, even in what you said around assessing a suicidal client, they can be very helpful because it gives you a framework by which to intervene. And it not only gives you a framework by which to intervene, but it gives you a sequence. You know, what do you need to do first? If the danger is the big issue, then obviously you need to assess for safety, right? So it gives you a nice sequence around what you need to do, but also when you need to do it. So, you know, again, we could play this out in a lot of scenarios, but the issue around suicidality is a great example of the application of these Ds to help you not only assess where your particular resident is, but how to frame and sequence the correct course of intervention given what they're presenting, right? And someone says the more information we can give providers, absolutely, right? And if they have a plan and so forth and so on. So yeah, I mean, information is important. It's critical. The more information you have, I think the stronger position you're in to intervene effectively and to do a good job. So that's a great example of, again, the application of this to a particular situation. All right, thanks. So let's talk a little bit about anxiety. You know, and I know there was some discussion in the slides around anxiety and how it presents itself. You know, obviously we've talked about this before, but there's a lot of ubiquitous anxiety. I mean, anxiety in and of itself is part of life, right? And when you think about anxiety, it's different than fear. Fear is one thing. Fear is a reaction to a stimulus, but anxiety is anticipatory fear, right? Because with anxiety, there really isn't a stimulus. When you worry or when you're anxious, you're worrying about what happened yesterday and what may happen tomorrow. So in a sense, it's anticipatory. You know, anxiety is all around. I mean, it's part of our human condition. When does anxiety become problematic? When does anxiety become problematic, or when does anxiety morph into something that potentially could be a behavioral health disorder?
So me personally, I've dealt with anxiety since I was little. But I knew it started becoming a problem when it was affecting me, not only mentally and emotionally, but physically.
Yep. Good.
I sought out a doctor to kind of help me with that, and I am on medication for anxiety and depression now.
Okay.
But I think it's when, I mean, there's normal everyday anxieties and worries and whatever. Like, it's just a part of life. But when it starts to affect your everyday life and it's something that just is affecting you in everyday life, and that's when it becomes a huge problem. And that's when I personally started realizing, like, this is affecting my life. Like, I really need to seek out some help. And ever since then, I've been good. So I'm very thankful for that.
Yeah, I appreciate you sharing. You're absolutely right. I think, you know, like you said, anxiety, there's a lot of normal anxiety that we all experience as a result of the stress in life, uncertainties and all the rest of it. But when it gets to the point where it creates functional impairment, and you talk nicely about that, when it gets to the point where it starts interfering with your life, as you said, then I think we're sort of morphing into an area where some kind of intervention might be appropriate. So yeah, it's not like we would pathologize anxiety in and of itself, but it becomes problematic or it becomes difficult or challenging when it starts invading aspects of your life. And, you know, you're right. I mean, anxiety has, you know, physical manifestations. It has thought manifestations. It's a feeling. It affects our behavior. So, you know, real substantial anxiety that creates functional impairment affects just about every aspect of our life. It affects all the realms of our functioning. So I think that's a great, it's a great point you made. Yeah. And, you know, depending, you know, on the amount of stress we have and what's going on in our lives and how much social support we have and how many, what our resources are, we can all of us can be, affected in a negative way by anxiety. So it's out there, and it's always going to be there. The stress is always going to be there, but it's we know with our patients and residents it becomes problematic when it creates functional impairment. So I appreciate that. That's exactly right. Right? A little bit of anxiety is good, like one of the slides says. I know when I get anxious about something, it helps me stop procrastinating. Sometimes if I've not done something, I get to a certain point where I start getting anxious about it, and that propels me, it gives me energy sometimes. But certainly more pervasive anxiety can be very debilitating. So thoughts about anxiety. The question is, how do you manage it? How do you help a patient or a resident manage it, right? What are appropriate interventions around anxiety? Well, obviously there are talk therapies, there are grounding techniques, deep breathing, counting, and sometimes medication. There are anti-anxiety medications to help people feel a little bit more normal. What does anxiety do to us? How does it make us feel? I know sometimes it makes me feel funny. It makes me feel like something is wrong, and I'm not exactly sure what it is, but I just don't feel myself. Sometimes it plays out a little bit somatically around sleep, or preoccupation with something. So anxiety plays out in many different ways, but we always have to be aware of when it becomes functionally impairing, and that's the time that you need to take some action, whether it's with a resident, patient, or even with yourself. So questions about anxiety? I'm not going to get into all the different kinds in the DSM, generalized anxiety, and some of the others that are in there. Separation anxiety, the phobias, panic attacks, panic disorder, social anxiety disorder, which used to be called social phobia. And lots of different ways that anxiety can play out. But what we're looking for is whether or not it's causing any kind of functional impairment. So I'm gonna stop there and just. Carla says about lockdowns in facilities. Yeah, I certainly. I have a little bit of claustrophobia. I can't imagine being locked in a. I have a hard time getting on planes sometimes when they shut the door. So, yeah, and you know what? The interesting thing about anxiety too that I'll mention, I think to some extent it's a little bit heritable. In other words, you inherit. I think there's a little bit of a genetic substrate to this, to some extent, just like there's a substrate for depression. And from my understanding, that genetic material, whatever it is around anxiety, kind of has a parallel with depression. So they're kind of they're in the same area genetically, the depression and anxiety. Sometimes there can be like two sides to the same coin. And I think that was mentioned. If you're anxious, you might have a predisposition towards depression as well. Okay. Right. Yep. Good. So any questions about anxiety in terms of what you read, what the video said? Any questions you want to ask me around applicability? How have you seen it in the patients that you work with? How do they manifest anxiety, and what have been some appropriate interventions? Pacing around, yep. Certainly having like some almost being hyperkinetic, a lot of energy, pacing around, fidgety, agitated, right? And giving them a simple task. What's the value of a simple task? Focusing, grounding, right? Focusing, grounding, having your feet. We talked last week about having your feet on the ground, feeling the earth, a grounding technique, right? Right. And Nicole says it's easy to accomplish, right? Kyle says always wanting liquids or fluids, drinking water or other drinks all day long. Yeah. I mean, I think that's a sign of being anxious too, in an attempt to sort of self-soothe. Anxiety is very common. It's probably the most common behavioral health disorder. I know that was one of the questions in the assessment, the pre-test assessment in your materials. Anxiety is the most prevalent behavioral health disorder. You know, you think about anxieties compared to the others. I mean, all of them are fairly more prevalent than you would think, but clearly anxiety is the most prevalent. And I think there's a genetic substrate to that to some extent too. Some people are just more anxious than others. Some people are just have a higher level of anxiety than other people. You know, we call that generalized anxiety disorder to some extent. You know, people are just seem to be anxious about everything, right? So it can morph into a disorder. Kyle, anything else you wanted to say about anxiety? You know, it's like something that we don't pathologize unless it creates functional impairment, because we all have it. We're not all mentally ill.
I wonder, I'm looking at Sonia's comments about people when they come off quarantine, staying in their room. And, you know, with the pandemic as an overlay, our anxieties are linked to this virus, and depending upon your age and your comorbidities, how it could affect you. And so I know that in the institute that I work for, we're seeing a lot of older adults isolate. They're demonstrating more symptoms of anxiety and depression. And their behavioral health needs have increased significantly because of some of this isolation that's been going on. And so it's great to see that you're kind of seeing that same thing. That's one of the reasons that this curriculum was so critical to get to long-term care, because we know that the clients in your facilities are being really affected. And we need to make sure that we're bolstering the workforce, because their distress can have reciprocal impacts on all of us, right? When you're working with them. And so that awareness and knowing how to take care of ourselves is critical.
Right, because again, like we were saying earlier, we sort of model functional ways to deal with anxiety. You know, and Tanya's right too. I mean, it's not just the anxiety specifically around being isolated, but it's the anxiety around the fear of contagion and potentially being around other people who may be sick and getting sick from them. So, you know, it's really kind of a weird commentary to suggest that precisely those people that you rely on to give you social support and nurturance and to help you get through life are precisely those people who could end up making you sick. So, you know, it's a lot of conflicted messages, and trying to navigate through all of these different areas of this that are difficult for all of us. You know, it's like I go out in public now, even go to the grocery store, and, you know, you get close to somebody and it's the look of fear in their eyes. And I feel the same way. You know, it's like you almost have become, there's sort of a distrust that's emerged in terms of dealing with other people. And I can certainly understand how difficult it would be in a facility where people rely so much on social support and connection. And now all of a sudden they're so disconnected. I know with addiction, you know, people who have mental health issues who need to get to see their therapist, and the value of groups and being able to be around other people is part of recovery. And now all of a sudden you're trying to do this stuff on a Zoom setting, you know, and Zoom is good, but it's not the same as being in the same room with somebody. You know, there's still a significant amount of disconnection. You know, I feel it when I try to facilitate these workshops and these trainings, that, I mean, it gets the job done, but I still feel like I have to work, that I'm working through a medium. You know, I'm looking at everybody and interacting with everybody through sort of a piece of plexiglass. And it's, you know, even that creates a substrate of anxiety, because sometimes I feel like I'm not getting through, or I'm not paying attention, or I'm not reading the nonverbals. You know, it's just an odd way of communicating. There's an artificiality about it. So, yeah. What are your thoughts? So, what do we do? What do we do? What do you do with the residents? What are some interventions? Well, I'm guessing you let them vent. You let them talk about what they're anxious about. You give them forum, right? You talk to them. You let them express their feelings. You try to be reassuring to the extent that you can. You teach them maybe some grounding techniques, you know, that work for us as well. Yeah. Give them space to express how they feel and to express their insecurities. And sometimes it's not about fixing anything. It's just about listening. It's just about sharing the experience that can be so helpful. So we don't have to be particularly sophisticated in our intervention, but what we have to do is we have to allow a space for that anxiety to be dissipated, to be discussed, to be talked about, and to be acknowledged, right? And then once that happens, then you can think about some strategy around trying to mitigate or reduce it. So, I mean, a lot of people are hurting. There are a lot of people are hurting, and they're disconnected, you know, and so, you know, like Tanya was saying, the you know, to be able to work effectively is so critical in this kind of environment. So, okay. Right. Yep. Carla says about showing them love. You know, I think, you know, that notion of caring, right? Of being compassionate, you know, like we had a little discussion about this last week, you know, and again, we can get compassion fatigue too, right? I mean, I can imagine, Carla, you're so forthcoming and so helpful and so giving that sometimes you can end up depleting your battery. So there can be, right? You're shaking your head. Yeah, a little bit of compassion fatigue, you know, and it wears on you. It wears on you, right? You give and give, and it's a wonderful thing, but at some point, right, you have to make sure you take care of it.
Me so well.
It's just good guesses. I'm pretty good at reading facial expressions, even on Zoom, right? Yeah. No, but I mean, I you know, it's like, it makes sense, you know. It's a wonderful thing to care about people, but it takes
Renee, did you want to say something?
No, can you hear me now?
Yep.
Yes.
That's why I saw you lighting up yellow.
Yeah. No, I was agreeing. I was going to say something earlier, but it's not really relevant now.
What's relevant? Go ahead. We'll make it relevant.
No, I was just going to say that with anxiety, sometimes it's the coping mechanisms that, so specifically personally for myself, I didn't realize I was dealing with anxiety, and then it was the coping mechanisms that I was using that when my therapist was like, it's because you have anxiety. Like, people always said I had OCD. I was like, okay. So I just thought it was quirky. Like, I just always thought I was like a quirky person. So, you know, I had my quirks, and then I just realized that. And as I've gotten older and, you know, you have these life transitions or life events, it's gotten harder and harder to cope with it. But, you know, we learn certain things to deal with it. But that was one of the things you were like, how are you recognizing that people are dealing with anxiety? And some of it is the coping mechanisms that are showing that they're dealing with it. That's what I was going to say before.
I think that makes a lot of sense. You know, sometimes though, the coping mechanisms that we have that we traditionally rely on don't work sometimes based on whatever we're dealing with, you know. So, you know, most of us have a repertoire of coping strategies, and they can be pretty effective, you know, and we're pretty good if we're able to pick and choose. You know, if we have what we would call a little bit of ego flexibility around making choices around what coping strategy we're going to use, you know. And some of it's the subconscious. It's not like we consciously think of, you know, we sort of go into these modes, these coping strategies almost automatically, but there are times that they don't work. They're not effective. And that's when the anxiety really builds in, because we try it, you know, and it doesn't work. And then we try something else and that doesn't work. And then it sort of escalates. It sort of escalates to a point where it can become a crisis. So, yeah, you know, and I think when it comes to residents and patients, I guess the moral of the story is that you want to facilitate a process with them that they can explore what their coping mechanisms or strategies are, so that when things do happen, they have things that they can turn to. You know, it behooves us all to know how to self-soothe. I mean, that's certainly one coping strategy. You know, when you're anxious or stressed out, you have to have ways to self-soothe. You have to have ways to make yourself feel better, you know, to get through that situation, even if it's just temporary. And some people don't have that mechanism. So yeah, I think coping strategies and mechanisms are exactly what we're talking about here in terms of anxiety, right?
You know, Dennis, one of the things that I'm wondering, because there's a wealth of experience on this Zoom. And so as you guys are interacting with current situations and the clients that you're taking care of, are there aspects of their behavior when you're concerned that there might be a behavioral health feature that you're struggling to try to navigate, and that that you're kind of looking for support on, that we might be able to connect to the materials that we've read when we're thinking about symptoms. And like Renee had shared, sometimes people call things quirky, and we toss labels around all the time. Oh, I'm so depressed. Oh, I've got OCD, all that stuff, without really understanding them. Is there a place that you're kind of trying to get your footing as you provide these quality services to your clients, where there are behavioral health factors that we might be able to kind of discuss a little bit tonight about?
Great. What do you guys think? That was a great question. Where have you seen anxiety manifest in your clients that you have difficulty sort of making that connection, or having a little bit of difficulty understanding what needs to come next? What would be potentially helpful for that individual? What have you seen? I'm sure you see a lot of manifestations of anxiety. Biting your nails, shaking your leg, constant movement. Yep. Those are certainly great indications of anxiety. Fidgetiness, we talked about that before. Impatience, sometimes irritability, agitation, short-temperedness, right? Yep, agitation, Nicole says, right. So to get to Tanya's question, what kinds of suggestions, what would you ask me around dealing with some of these manifestations of anxiety in terms of what might be helpful in terms of intervention? What do you think? Well, certainly the relaxation, deep breathing, grounding, focusing on one thing at a time, helping the client focus, sort of ground the individual or the patient, right? Those can be strategies. What else? What do you guys think?
A good family friend of mine taught me a really helpful breathing exercise where you put one hand on your chest, one hand on your back.
Yep.
And you feel like you inhale for 5 seconds or 6 seconds, something like that. Hold it for 6 seconds, let it go for 6 seconds. And you just focus on your core and really focus on the deep inhale, holding it, and then the deep exhale. And it's helped me a lot.
Yeah. I mean, I think it's great that you said that. I think I read an article a while back. Even a couple of very deep breaths can calm someone down. There's a physiological aspect to sort of deep breathing and paying attention to your breathing, breathing in a way that's sort of controlled, and that really can help. Carla says focusing on the here and now. Yeah, I think that's another issue that, I'm glad you mentioned that, Carla, because I think, the notion of being present oriented, and the whole notion of meditation and the value of mindfulness is what we would call it in a sense, being mindful, kind of staying in the moment, staying in the present. I think that certainly is helpful, because again, so much of anxiety is anticipatory. Like I said before, it's not really fear, because with fear, the stimulus is there. With anxiety, it's anticipatory. There is no stimulus. You're worrying about it. You're anxious about it. So yeah, being mindful and being present oriented and helping the resident or the patient be present oriented can be a very effective strategy. Focusing on what's happening now and engaging in that grounding can be very, very helpful. It can be helpful for all of us, really. Right? When our thoughts start running away and they escalate, and who mentioned OCD? I think there was somebody had mentioned, that there was some possibility. Well, in the old DSM, obsessive compulsive disorder was in the anxiety disorders chapter. So clearly there's a substrate of serious anxiety in obsessive compulsive behavior. That's what sort of drives the obsessions and compulsions, is that anxiety. And the more you try to mitigate that anxiety, sometimes the more obsessions and compulsions you have, right? So there is that strong connection as well. All right. Well, I think the trick with anxiety is to know where the line is. Is to know where the line is, because clearly we live in an age of anxiety. So try to figure out where the line is, and we're trying to be self-aware enough to know where things are going off the tracks, you know, so that it doesn't go on too long and there's not more significant damage. And then Nicole says around limiting the noise or chaos. Yeah, sometimes we're so bombarded by all of these external stimuli, you know, and especially now when we're doing everything through electronic media. Sometimes just turning that stuff off and just you know, being calm and quiet and focusing, you know, that's the value of meditation. Listening to your inner voice that gets so lost by all of the voices that are coming externally. So maybe that's something you can work with your patients too, just about getting calm and getting focused, and you know, and helping them get to that place. And it's something you practice, right? You practice every day, and then the more you practice it, it becomes almost intuitive. Exercise can reduce anxiety, right? Working it out physically, you know, walking, going to the gym, right? Sort of dissipating all of that fidgetiness and that those behavioral manifestations through exercise can be hugely helpful too, right? So yeah. So it's it's an issue of increasing awareness, not only for yourself but for your patients. Mm-hmm. All right, I got 9:15. Do we need to take just a 5-minute break? And then I want to talk a little bit about PTSD and a little bit about depression. I think those are the kinds of things. And again, PTSD can cause a lot of anxiety as well. Do we need a 5-minute break? What do you guys think? Yeah, okay. I'm getting the high sign from Tanya. Cookie says yes too. She got a smile on her face.
Yeah.
All right, let's just take 5. I've got 9:15. We'll reconvene at 9:20.
Let's go.
I didn't get that email.
You didn't, huh? I sent it to everybody.
No, I don't get it.
Okay, I can resend it. No problem. I'll resend it, Helena. No worries.
Tanya, can you hear me? Hi. Now I'm like, I don't know if you can hear me now. So, but I see my microphone. Does that go up and down? No.
When you're talking, the green will, yes.
I don't think it's on here. I'm on the computer and the phone. But in any event, I missed the very beginning where you talked about those resources. So will we get a recording? Should I look at it then, or will it be sent via email? What do you think?
I think I started it right when I started to talk about them. And actually, Omar is going to be coming to class next Thursday to talk specifically. One of the things that you probably definitely missed is that the resources are available through, once we register how many people we have in the class, that's the link for those. So I had sent out an email today to all of the folks involved on the Zoom links with a copy of the form. And I also pasted the steps in the email, but a couple of folks on here have said that they did not get it.
I think I
like
might
Helena
have
didn't get it.
gotten it. Let's see here.
I think somebody else said that they didn't get it. You didn't get it either, Nicole? No, okay.
Is this a mandatory registration for BH training?
Yep, that's it.
Got it.
I still didn't get it.
I'm gonna check.
Did you send it to me again?
No, I'm looking right now to see when I sent it out. Let me search by mandatory. Let's see. Did everybody in the, sometimes I think that sometimes I think that sometimes people's my email to people gets stuck in their spam when it comes from the college. So Renee, it got sent. You got it.
I got it. I did get it.
I'm looking for Nicole and I'm looking for Helena. Let me see what happens if I forward. So Helena Salvador, I'm going to send it directly to you. And Nicole.
Block. What? Haven't blocked. No.
Tanya, could you please send it to me too?
Yeah, who's that? Is that
Jenna.
Jenna?
Yeah.
Yep.
Thank you so much.
Yep, no problem.
I still didn't get it.
So hold on, I didn't hit send yet. jbrody@gmail, and I'm just trying to capture. I want to
Raquel.
Nicole. I want Nicole's email. And Nicole, you wanted that zip spit of heaven? Let me get back into the Zoom so I can see you. Is that good, Nicole? Do you want to give me a thumbs up? Okay, perfect. All right, and I'm sending it right now. Hello. Oh, hey, Peaky. All right, perfect. Okay, so I just sent it. So let me know if you got it. I know, Peak. Oh, yelling. My cats are circling my feet like sharks. They're going around me in circles.
I think that they want attention.
They do. That's exactly what they want.
I feel like you're sitting there, you're not paying attention.
Mm-hmm.
How dare you not pay attention?
This is cuddle time. This is the time that I'm supposed to be cuddling with them.
Oy.
All right, let's see.
My children are doing the same.
See, all right. I'm glad it's not just me.
You know.
For scenarios. Damn it. I'm looking for something. Damn it. How you doing, Laura? Let me see if I can unmute you. No, I do not have the power. There you go.
Hi.
How's it going?
Good, good. I'm enjoying the class.
Yeah, I'm glad.
But I
It's,
missed from the last class.
oh, good. And I'll be able to publish all of the videos so you can kind of catch up with them. I'll put them right in the Google Classroom. Sometimes it's easier if I turn the videos, the pre-work videos, into YouTube videos, because then I can just send you a link and you can get it from anywhere. When I send it from the Google Classroom, if you're not in it, people can't always access it. So I like to kind of to convert all the videos that way. It makes it a little bit easier.
Turn them into YouTubes.
All right. Thank you.
You're welcome.
Yeah,
Thank
good.
you.
All right. Tanya, did everybody sign the permission form around recording?
Yes,
Good.
it should be good.
I didn't. That's my fault.
Who didn't?
I don't think I did.
I
Renee?
think you did. I have you on because you started out on Monday night.
Oh, okay.
Yep. So you're good.
Oh, okay.
All right. So you did it in the other cohort. So you're good to go.
Oh,
You're
okay.
good to go.
Cool.
Good. All right. All right. Thanks, Tanya.
You're welcome.
It's
And, I was looking, we have the vignette that around the stages of change, and and I wonder if I was looking to see if we might find one working with an older adult. So maybe while you're talking about the next two pieces, I can look and see if I can find something and we can save the stages of change.
great. Okay, sounds good. I want to talk a little bit about post-traumatic stress disorder. I think you had some material on that as well. And, again, it does tie in to some extent to anxiety, because people who do have symptoms of PTSD do have signs of anxiety. So what's your knowledge of post-traumatic stress disorder, or how have you seen it in the residents or the patients that you've worked with? How have you seen it made manifest in the people that you've worked with? Sonia, have you seen any examples of PTSD or symptoms of trauma in the individuals that you work with, the residents? Carla says that her father has. Right. Yeah. One of the when you think about the symptoms that are associated with post-traumatic stress disorder, it's like Carla said, flashbacks are one of those symptoms. What are some of the other symptoms of PTSD? Right. And right, flashbacks can be triggered. Sometimes they come out of nowhere, and paranoia, maybe alterations in thought, alterations in mood. Sometimes dissociation, can be part of PTSD. Do you know what dissociation is? Does anybody have an idea what dissociation is when someone is dissociative?
It's not being able to determine reality from what's not reality.
Yeah, dissociation, right, is sort of a disconnection between what's going on around you and paying attention to external stimuli. The person is a little bit kind of disconnected. We all have the ability to dissociate some. Sometimes I have long car trips back home to Cleveland. And sometimes when you're in the car and you're driving and the scenery looks the same, sometimes you just go into that zone, and you come out of that zone and you've gone 300 miles and you don't really remember exactly how the hell you got there. So dissociation is sort of that disconnection between what's going on. And you see that in PTSD. In some ways it's protective, because whatever happened to that individual was so difficult to deal with that the person just shuts down. They become disconnected, and you see extreme forms in it in dissociative identity disorder, which we used to call multiple personalities. I don't know if you've ever heard about that. People who have multiple personalities, that's a form of severe dissociation. So, PTSD is the fight or flight. there's been a traumatic event that the person has experienced or witnessed vicariously, right? And that the trauma causes symptoms, like we talked about, some of the symptoms that we've discussed. They have to last for about a month, at least, to make the diagnosis of PTSD. So they have to go on for at least 30 days. Yeah, I'm not going to bore you with some of these details, but it has to go on for 30 days. If it goes on less than 30 days, it's an acute stress disorder. So we have different ways of classifying these, but clearly PTSD has to go on for that duration. And it can be a very debilitating disorder. The good news is that it can be pretty effectively treated. It can be effectively treated. And so what's your experience with clients who've been traumatized? My sense is that many of the clients or residents you work with have had sort of ongoing trauma. I mean, being homeless, dealing with some of these issues can be traumatic in and of themselves. Failure to thrive, yep, that can be refusing to eat, failure to thrive. Those can be indications that there's trauma. What else? What have you seen? Kyle? What have you guys seen around PTSD in terms of the people that the individuals, your residents you've worked with? A lot of them, again, have had a lot of traumatic experiences. What are some of the symptoms that you've seen?
Repeating the behavior.
What's that?
Repeating the behavior.
Yeah, kind of reliving the experience, you mean? Yeah, absolutely.
Like, like if they're like, sometimes you walk into a client's house and they could be like haughty. So it's hard to take care of them because it's a lot of, it's unsafe sometimes. Right.
Isolation is another example that someone mentioned. Timidity, being timid, shy, can be symptomatic potentially. There are situations where people have symptoms of PTSD, but they don't remember the trauma. They're not able to point to a particular trauma. Nicole says extreme reactions. Yeah. Sometimes you can be triggered and have very, very uncontrollable reactions. I had a close friend who was in Afghanistan, and I remember we were at a fireworks presentation on the 4th of July, and that was a mistake because the fireworks caused him to really have such difficulty listening to the fireworks that we had to leave. He was able to control himself, fortunately, but because he had good therapy. But the fireworks were very triggering, very triggering. So that can be another manifestation as well, right? Sometimes around suppression of memory, yep, and so forth, and resilience. I think that there's a slide in there that talks about risk factors and resilience factors around PTSD. I'm not going to go down the list, but if you have a chance, you did look at that, I would take another look at it. It talks about what are the risk factors in terms of developing PTSD, and also what some of the resilience factors are. There are some people that are just resilient, and the material talks about what some of those factors are. The good news, as I said, is that there are some good treatments. Good treatments for PTSD that are very useful. Do you know of anyone who's been successfully treated who has PTSD, who had a good outcome? Anyone? Anybody have a good outcome that you've known who's had symptoms of post-traumatic stress disorder? Have you seen it in the residents? Carla, have you seen any residents that have?
I don't really see the PTSD portion. I have a resident who states to me all the time that she molested one of her children, which is a fabricated and untrue story. And they've been like this research, like she's been through therapy, and in her head, that's what she's done. And that's the only and it's not even a true story. And that's the only resident that I really see that has any type of PTSD at all. I don't see many of that at all. I see the more anxiety, the depression, the hallucinations. I see stuff like that. I really don't see the PTSD. Only with my father. I have, and my dad's at the VA, and he gets, talk therapy, and he does well. But I don't see it.
So you see it more from a personal perspective.
I do.
Right.
Dennis,
Okay.
what's the likelihood? I know one of the things that I've come into contact with in our work with within assisted living facilities and adult daycare in our dementia work is that as people get older and we're not privy to their history, that we may not be looking at them with a trauma-informed lens to think about the possible presence. And so we think, based on the presenting information, nothing seems to be going on. But I have a colleague who does some training for us on dementia, and she shared a story about in one of the nursing facilities asking an older Jewish woman if she would like to take a shower. And it put the woman into such a state of panic. And the person who asked the woman did not realize that she had been in a concentration camp during World War II. And she had the Nazi tattoo on her hand. And it didn't even occur to this person that asking her, as opposed to, can I help you wash up? But that word was a trigger for her, and it was terrifying. And the poor staff person wasn't prepared for it, and neither was the woman. I think sometimes we don't know what someone's trauma history is, and we might not realize what's triggering that. And I, with Carla's example, if that woman might be projecting her own victimization as a child, but maybe
in her thoughts about that. Yeah. And again, sometimes because, sometimes, it's, and these are errors of omission that are not intentional, but, sometimes we don't do the assessment that we should. And sometimes the clients don't have a full understanding. The traumatic experience could have happened, but they don't connect the dots either. So they're symptomatic, but they don't realize where those symptoms are coming from. I'll tell you where else it happens, Tanya, that I've seen is that kids get diagnosed with learning disabilities. They get diagnosed with ADHD, right? And really what's happened is that they've been traumatized, and that the reason they have difficulty in terms of being attentive or focusing, or they're hyperactive, is because they have a trauma history, and they get misdiagnosed. They get diagnosed with a learning disability only to find out that there's traumatic material there. So I think part of it, as you said, is that we're just not as we're not as vigilant about doing a good assessment and getting the history. And then I think sometimes clients, they don't make the connection. I think with men, particularly because of all the socialization around, it can't happen to you. Sometimes it's covered up, or it's masked, or it's so the person feels so guilty and somehow like that they deserved it, that they don't even bring it up with the therapist. So again, they manifest symptoms, but it's not clear what the etiology is. So yeah, so I think we all have to do a better job of having that, as you said, that sort of trauma-informed lens, to make sure that if we see symptoms, we always at least consider that they might be caused by some traumatic experience, and then to do a good assessment. But to do it in a way that's sensitive to the fact that the client might have a lot of difficulty going there. There's a lot of resistance to bringing up that material for a lot of reasons, because in some ways it's difficult to control once it starts, once you start talking about it and that material is accessed, then sometimes you don't know where the bottom is in terms of how bad it's going to be. So there's a lot of resistance in the work, and I think there's sometimes reluctance on the part of the clinician sometimes to go there because of some of their own issues. So I think it's a kind of a complicated situation, but I do think there's a lot of misdiagnosis around it too, particularly with kids who get diagnosed with learning disabilities. Yeah. So good question. Does that make sense to you guys? Laura's kind of sitting back against the wall, trying to rest a little bit here, right? What do you think, Laura? You're resting a little, right? It's that time. Okay. PTSD. right? It's been in the DSM, in the Diagnostic and Statistical Manual, for a long time, and it's every time a new edition of the DSM comes out, there are changes. It's one of those diagnoses that has probably been changed more than any other diagnosis in the DSM. Every time it comes out, there are new revisions. The latest revision had to do with being vicariously traumatized. So now you don't have to experience the trauma yourself. Sometimes if you witness it, it can be enough to create symptoms of PTSD. I want to talk a little bit about depression while we're on all these happy topics. Depression, again, is sort of misunderstood in terms of the lay public, right? I mean, depression is not just sadness. Sadness is a normal experience, just like anxiety is a normal experience. But depression is something more than that. So when you looked at the slides that talked about depression, what do you think? What's your sense of what depression looks like? And how is it different than just being sad? Renee? Is Renee out there? I don't see the...
Me?
Yeah, you.
I'm here.
Good. I'm glad. I'm glad.
I'm here. I was actually just gonna pull up the slides about it because I didn't actually get into anything until like now. We were having some trouble registering, but in any event.
Yeah, go ahead.
So somebody said to me that anxiety is I think it's the fear of falling, and depression is you're already there. I think that's what they said to me.
It's interesting.
So,
yeah.
So to me, the way that I think about it is like anxiety is about the future and depression is about what has already happened.
Yeah. That's interesting. Yeah, right. So you're anxious about tomorrow and you're depressed about yesterday. Yeah. That's interesting. Yeah. Or you can be both, right? You can be anxious about tomorrow and depressed about yesterday, right?
Yeah.
Depression is, it really affects, again, we think about anxiety and the functional impairment. It's the same with depression. Depression causes a lot of functional impairment. And, it's not sadness. Sadness is a normal human emotion. This is a situation where the person has a lot of cognitive symptoms. They have a lot of emotional symptoms. They have a lot of physical symptoms, and they have a lot of behavioral symptoms. So when you think about depression, again, it's kind of like anxiety that's pathological in the sense that it affects all these spheres of functioning. And certainly it can interfere significantly with daily living. So when you're depressed, what you're thinking? Your guilt, you feel guilt, you ruminate, you say a lot of negative things to yourself, a lot of very self-denigrating things to yourself. When you're depressed, you might feel very sad or hopeless. And sometimes it's beyond sad. Some clients that I've worked with are beyond sad. They feel empty. They don't feel anything. There's no emotion at all. And then when you think about sort of the behavioral manifestations of depression, you think about not being able to do your ADLs, not being able to sleep. Sometimes depression can feel like agitation and restlessness. It's not always just sadness. It can be restlessness. You feel, what would somebody say in chat, which is a good point. You feel like you're a burden. You feel guilty. You feel like you have no worth. You feel hopeless. You feel helpless. You feel trapped. Sometimes you don't feel anything. You feel empty. And you have a hard time just doing anything. If I have a difficult time gaining any energy. And the thing about these mood disorders, particularly depression, is that there can be a lot of suicidality to this too. So depression can be extremely debilitating, and it can cause a situation where the person doesn't want to go on anymore. And so when you're working with someone who has depression, that particular mood disorder, then you have to do an ongoing suicidal assessment because they clearly are a risk of harming themselves. When you think about it, I mean, who would want to live like that? And when you get to the point where you don't have any hope, you become hopeless, then things can get very serious. So again, remember those 4Ds we talked about at the beginning of our Zoom session tonight? You can equally apply those 4Ds to depression, right? There's the same 4Ds apply to depression in a different way than anxiety, but they're equally applicable. Certainly the danger piece, when someone becomes suicidal or homicidal. The deviance, you see the person very much different than their baseline. So when I work with clients with depression, I always try to get a sense of what they were like before they were depressed. You know, what their baseline was. What were they like before they became depressed? And what you typically find out is that they're very, very different. They're very, very different. Have you guys worked with clients who have depression? Have you had opportunity to work with clients with depression? Nicole asked a great question. What do they need to be to support them? That's a great question. Well, first of all, they need to be heard. They need to have a space, an opportunity to express where they are. You know, they have to be validated. You know, the last thing in the world you want to do is to try to talk somebody out of depression. Kyle says she has a resident who sleeps almost 20 hours a day. Yeah. What you see is either hyper or hyposomnia. The patient either sleeps too much or doesn't sleep enough. But getting back to the question that Nicole asked around support, you know, they need to be validated in where they are. You need to be emotionally attuned to them. You have to make a connection with them, you know, from a feeling perspective. And you don't want to talk them out of anything. You want to accept where they are. And the other thing I tell my students in working with clients who have depression or patients with depression is that you always want to try to stabilize them. You certainly don't want the situation to get worse. So typically the first order of business is stabilization. And you try to keep them from getting worse. And how you do that is by building in social support, by making sure that they're connected, they don't become increasingly more disconnected, by assessing their suicidality, by being emotionally attuned to their depression, by allowing them to discuss it, to talk about it, and to validate those experiences, because you're not going to talk them out of it. I mean, it's not something you just talk them out of. So what have you found that's been helpful with clients who have depression? What have you seen that works in people? So there's medication, antidepressant medications that sometimes can be helpful depending on the kind of depression it is. What have you seen that's been helpful?
Dennis, you know what I wonder? I wonder if maybe if we let people get a little one like small group time.
Okay.
I pasted a little scenario in the
Great.
chat.
Want to do that? Sure.
Can you guys see that? Maybe I didn't hit send. Okay, now it's in the chat. Critical
in chat.
So
Okay.
I have little groups broken up. It's just a really quick down and dirty, but it gets at some of the issues that we've been talking about tonight. And I just wonder maybe the question that Dennis just posed about, what do you think that we need to do? Maybe we could use James as a kind of an opportunity to apply some of what you've learned in the pre-work. Maybe have like 5-minute conversations and then come back and process it.
Great. Sounds like a plan. So everybody has it in chat. You can see a 77-year-old single widower. So take a look at that real quick. And then I think Tanya's going to break us up into some groups. Can you let me bounce around a little bit, Tanya?
Yep, I'll make you a co-host.
Great.
So then you can jump into anyone's rooms and I can go into some too. So I'm just gonna send you into groups, and then I'll come in and I'll repaste the narrative in case it doesn't show up in your chat. Okay, so you don't have to worry about getting in there.
All right.
So here we go. The magic begins.
Where are we going?
All right, so can you join a room, Dennis? Do you have the ability to join?
Yeah, I'm with, yeah, I can do that.
If you want to jump in, I'm going to go make sure everyone has the narrative.
Sounds good.
Hi.
Do you need me to paste to put it in your chat here? Can you see it? Oh no, you can see it. James is 77.
I can't see anything.
Me neither.
No? Okay. Hold on. So let's see.
Yeah. From. Oh.
All right, can you guys see that?
Yeah.
Yes.
So I just wanted to give you a chance to talk about it a little bit. Like, what do you think is going on with him? What is relevant to what we learned about this week? And, you know, do you have any suggestions if you were working with James, what you guys might do? So I'm going to see. Cookie, I'm going to see if I can put it in your chat so that you'll have it. Can you see it? I just sent it to you.
Yes, I see it.
Okay, all right, so I'm gonna pop out and leave you guys alone. I don't know if the screen will stay up in here when I disappear. If it doesn't, Cookie has it in hers and she can share that with you. But I will, I'll bring you guys back. I'll send a message and we'll just pop you back in the main room.
Okay.
All right. I just have to figure out how to go. I'm gonna stop sharing. Maybe that will help me. There we go. All right, perfect. All right,
Hey.
I'm jumping back into the other one. I'll be right back.
Right.
Hey guys, how you doing?
Oh, hi, Tanya. I just sent you a message
Yep. Can you
on your
guys see
email.
the chat?
Not the class one. We can see our own one.
Can you see James is a 77-year-old?
No.
All right, so I'm gonna send that to you to share with your group, Renee.
Okay.
And tell me, I'm just sending it now. Tell me if you can see it.
You send it on my email?
Nope, I sent it in the chat.
Oh, in my chat. Okay, go. Yes. Okay, yep,
All
I got
right,
it.
so if you can read that and just maybe take a few minutes to talk and see, you know, what in this little brief scenario would give you some concerns, what's connected to class, and then I'll bring you guys back in like 3 minutes.
Okay.
All right?
I think we got it now.
Okay, perfect.
Can
Thanks,
everybody
guys.
see the scenario now?
I can
Laura,
send it
are you
to
there?
everybody.
Yeah,
Okay. Yep, Sonia's on
Yes.
too. Okay.
As
Good.
soon as I pop out, I think it will pop away with me. So let me just,
Oh.
that's why I'm emailing it to all of you, so you'll have it.
Oh.
And I think Kara, I don't think I gave it to you, so I'm gonna paste it there. Okay, there you go. And worst case, Renee, if you could just read it and kind of bring everyone together around a discussion.
Okay.
All right, awesome.
Perfect.
Thanks.
I got it. Yeah.
There she is.
One more, Manoj.
Where's the group?
They're in there. Do you want me to put you with group 1?
Yeah, that'd be great.
All right, let me assign to
With
group
group.
1. There you go.
So we decided that he would need to maybe enroll him in like a gateway, a fund administered community care alliance, like a mental health portion, so that he could maybe go to a meeting,
Yep.
see who he has for a support. You know, does he have any family support? Is there someone that he can turn to? What his hobbies are, and kind of, you know, get him into a program. And lastly, we thought medication, because we wanted to see if we, being 77, we wanted to see if we could deal with the other components before we brought medication into the mix.
What kind of issues is he having that are sort of a manifestation of the depression?
Maybe his, you know,
Hey guys,
It's not the,
sorry, just floating around.
this is really hard.
What do you think is hard about it?
I know you showed it to us, but we can't see it.
So you don't have it in your chats?
No.
No.
So let me just find my whiteboard again.
Here she goes again. It's out the biggest view.
There we go. So we're dealing with a guy who's 77.
Yes.
His wife died a year ago. He'd been in recovery from alcohol addiction for 20 years, but started drinking again about 9 months ago. So his wife has been gone for 12 months. He lasted 3 months before he started to drink again. He lives alone and he's isolating except for trips to the liquor store and the market. And when he last saw his primary care physician, the PCP expressed concern for the current situation and recommended that James seek help. What kinds of, what are you seeing in James that that might connect to what we learned about in class? And, you know, what do you think about a situation? Do you have any concerns about what he's going through? You know, what do you think might provide some help for him?
Well, we really just talked about, you know, being caregivers, there's only so much we can do. So we talked about reaching out to the appropriate people that can take him through the steps of recovery
Okay.
and
So-
therapy too.
So looking for some external resources. Have you guys ever dealt with folks in this situation?
No.
No.
Someone who's kind of lonely, they just went through a traumatic life loss, you know, and how that could maybe
Oh.
challenge his sobriety.
I just touched something. What did I do?
I think you turned off your camera.
Oh, how did I turn my camera?
Do you see the little icon? If you click it, it might come back on.
Oh, shoot.
Can you still see us, Cookie? Oh, there you
Okay.
are. There you are.
Yeah. Okay.
You got help in your house. Send them over to my
Yeah.
house. I've been having trouble all day. So this is not something that you guys have had to deal with,
No.
right?
Not yet.
So if you were, would you say that there might be some evidence of that maybe not a full depression diagnosis, but that he's dealing with some grief, and he might be self-medicating with alcohol?
Right.
Yeah.
Mhm.
Yes.
And isolating is probably, what else is he doing when he's by himself, but probably drinking,
Drinking.
right?
Okay.
So, and at 77, that could start to affect his health. So I love the idea of going out and getting some folks who work in the field of addiction to provide support to him. He's already connected to his PCP. So you have the beginnings of a good little team around him, right? But this is some of the kind of stuff that we might be seeing. And our go-to might not even be thinking about him having issues of depression, right? And who knows what his history was and why he drank before. Was he self-medicating then, right? This is a good opportunity to get in there and try to get some information. And like you guys suggested, connect him to some other people. I'm gonna pop out and bring the other groups back. And then we'll, Dennis, I'm sure we'll let people go around and do a process, and then we will wrap up the class. I'll take you out of the room so you don't have to do anything, okay? So just sit tight and I'm gonna pull you out.
All right. Thank you.
You're welcome.
Thanks.
Let's just see if I can get out first, Cookie. If not, you can send your helper there over, 277 Norwood Avenue. All right, there we go. I found the box. All right. All right, leave break.
And return to main session.
Hey, Jenna. Hey, Renee.
Hi.
Like magic, I waved my wand and everyone came back.
So you're definitely going downstairs?
We, Sonia was chatting, Laura was talking, I was talking, Kiara, we didn't hear. I don't know if she's there, but she could be doing other things sometimes.
Okay, yeah, and I
Yeah,
know sometimes
multitasking.
people have had connection issues, so they might hear us,
Yeah.
but they can't, and depending upon how
Yeah.
they're connecting, so we had I got a chance to spend a little bit of time in group 3 so I could put up the image. Group 2 already had it in their discussion, so they were going and I saw that they were set in group 1.
Yeah, group 1 was set. I had some problems jumping around in terms of the, anyway.
I think that I should have maybe bounced you around. I thought by making you a co-host, Dennis, that you could go wherever you wanted to.
But I don't think I could, Tanya. I looked at, maybe I'm missing the buttons that I have. I tried, but.
Okay, so next time I'll be more attentive to, instead of poor Dennis, we left him flat in the main room.
And I had terrible separation. And I'll tell you something. I had terrible separation anxiety. I felt all alone, like when I was a kid, and everybody left the playground.
I wanted to create an authentic experience related to the topic of the class.
I even had a little bit of dysphoria. I was going to become kind of depressed, being left. So what'd you come up with in terms of, dealing with this 77-year-old guy who had a lot of grief and so forth and so on? What would you recommend?
Counseling, definitely counseling.
Okay.
What kind of addiction facility to be enrolled in that can be able to help with AA meetings,
Right.
Groups of same hobbies or interests and age.
Great. So what do you think he was using in alcohol? What's the relationship between the depression and the alcohol in this 77-year-old? What do you think the connection is between these two issues?
So it's usually used as like a self-medicating or coping mechanism that they feel that they drink. It's helping to relieve their depression when it's making you feel better. It's
exactly
really helping.
Yep, I think that makes a lot of sense, right? So in a sense, the drinking is sort of self-medicating the misery or the suffering that's going on because of the depression, right? Good. Yeah. What about age-appropriate treatment for a 77-year-old? What other kinds of issues or needs would he have, given his age and where he is developmentally?
More attention. He needs like somebody to go check on him twice a week.
Yep. That's good, Helena. So it would be more like making sure that he's not isolated or too disconnected from other people.
So you'd be worried about like health, like being that his mobility with alcohol could also interfere with possible risk of falls.
Yep.
Another issue.
Exactly. I think that's a great point too. Or even the interaction, if he's got medical conditions and he's taking medication legitimately, the alcohol could interface with that in a negative way as well.
Yes.
So that's right. Right. I would think a group might be a good thing for him in terms of socialization.
Yep.
If he would be willing.
Grief.
Yep, around grief, absolutely. Why? Because it seems like he's got a lot of unresolved grief, and that could be a catalyst for the depression.
Right.
Right.
Did anybody wonder about maybe his earlier active addiction with alcohol? And was he struggling with anxiety or depression back then and self-medicating and then got himself into recovery? Like, what's his history? We're not just looking at a 77-year-old guy who just came into being today. He has 77 years of experiences that might contribute to us understanding, why his go-to when he lost his partner was to start drinking again. And I think when we're working with older adults, sometimes it's hard to think about what they were like before they were these older people that we met. And there's a lot to be learned from that.
Right. So I think doing a good history. Yeah. Cookie.
I was just going to say that sometimes I think, and I'm not sure if this is true, but we prescribe, not we personally, me, but I'm just saying medication is prescribed without, like, as a Band-Aid. Mm-hmm. But if you don't get to the core, like Tanya was saying, like, why was he drinking? It's like, was he why was he using that as a coping skill? So if you learn why, then you can focus on that and change the behavior and change.
Right.
Does that make sense?
Yep.
Yeah, absolutely. Absolutely. I mean, helping him connect the dots around, what's going on and what the history is of that, could be hugely helpful. But I think, the socialization piece is real important too, because I think, the risk of becoming increasingly more disconnected from others would exacerbate the depression and the drinking. So I think that needs to be in place as well. What do you think, Cookie?
I'm thinking.
You're thinking. Yeah, great. All right.
So thanks for indulging me with the group activity. I was curious to see how it would go, and if we could make some of those connections. So next time I'll just do better for Dennis.
Right. So that we all have to learn how to push the right buttons, right? So that we don't become isolated and depressed or anxious even,
Not
right?
me.
Or mildly anxious. All right. Real quickly here, because I know we're kind of running out of time. What are the takeaways here? What are some of the things that you can take from our Zoom meeting tonight, beside all the mechanics and all of that good stuff? What's sort of the takeaway from some of our discussion around some of these disorders? What are you thinking about that you can take away?
Gain more of an understanding of the differences between certain disorders and even sometimes similarities, and how to help residents dealing with certain behavioral or mental disorders or such.
That's great. Yep. I think that makes a lot of sense, that there are differences between these behavioral health disorders, but there's also similarities. That's a great point. And then that whole notion of, kind of paying attention to those 4 Ds and how they apply to these disorders, such that you have a better sense of what's going on and how you intervene. What other takeaways from this, you guys think? What other kind of learning happened in the Zoom meeting that you're going to be able to apply to your work? Anybody?
I know in my group, Dennis, we talked about that this isn't something that they had a lot of experience with. So
it's new.
so the opportunity to expect the unexpected, and that, I've been in school for a long time, but I encounter things on a regular basis that I have never encountered before, that I don't know how to deal with.
Right.
And so getting exposure through this kind of a conversation, and I don't work directly with older adults.
Right.
So I can learn from your experiences and how you guys talk about, approaching things carefully, and meeting people where they are. But I mean, I think even if this is new, it's an opportunity to think about statistically speaking, you will encounter some of this somewhere. And probably not too far in the distant future.
Right.
So
and having some familiarity with this content and sort of thinking about these things will create a little bit of a portal into your work, so that when you do interface with these issues, they're not going to feel maybe as strange or odd as they might if you didn't have this exposure. So this is kind of an area where you sort of get eased into it, but you certainly will have experience to deal with people who have these behavioral health disorders. So it's good to have the exposure. Good to have the exposure. You guys did a good job. I know this 8 to 10 is a little bit of a challenge, right? Time wise.
we gotta drink some coffee.
Yeah, right.
Then you won't go to sleep.
Right. What is Nicole saying? She's shooting some good stuff here in the chat. I just want to make sure that
Staff observing changes in depression or anxiety increasing and acting earlier on has a better result. Exactly. So prevention. So noticing stuff before it really blows up.
Right. And sort of doing a preliminary assessment, because as we all know, the sooner something is addressed, the sooner something is assessed, then the sooner the intervention can happen. And if things go on without that intervention, they only get worse in many cases. So the earlier the better. I guess that's the moral of the story, right? Eyes and ears, right? No, just paying attention. All right. So I think we're at that magic time of the night where we're going to wrap up. Tanya, did you want any more housekeeping things or anything that we?
No, I
We're
think
good?
we can wait till next week.
I think we're good. And then Omar will come next week around discussion of the wraparound. And maybe I can talk a little bit, remind me next week, we'll talk a little bit about the final.
Yep, you got it.
So we can discuss that. All right, you guys have a great night. Thanks for the involvement.
Thank
And
you.
you guys stay safe, okay?
Yeah,
Thank you
everybody
so
take care.
much.
You.
Take care.
Thanks for your
Helena. I'll
time.
be thinking about you.
Okay.
Thanks.
All
Thank
right,
you.
thank you.
Bye-bye.
Bye.
Thank
David. Bye, guys.
Bye. Thank you, Tonya.
You're welcome. Thanks for getting on, Laura. Great to meet you.
Same here. Thank you.
You're welcome.
Looking forward to seeing you next week.
Excellent. Me too. Me too.
Bye.
Bye-bye.
Bye. Thank you.
Thanks for joining us, Carla.
Thank you for having me.
Welcome to the
Bye,
crew.
Renee.
I'm excited.
Oh, good.
Bye.
Excellent. Excellent. All right. Take care, everybody.
Bye.
Bye, you too.
Bye-bye.
Do you need help leaving?